The following podcast is part of a certified educational activity titled Systemic Juvenile Idiopathic Arthritis, a closer look at the burden on patients and caregivers from diagnosis to treatment. Access the entire activity and complete the post-test at www.peerview.com/AVC. Downloadable slides and practice aids are also available.
Hello, my name is Randy Cron. I'm the Director of Pediatric Rheumatology at the University of Alabama at Birmingham. And I'll be talking today about children with systemic juvenile idiopathic arthritis, about the signs and symptoms, the disease manifestations, how we diagnose the condition, some of the comorbid conditions that come with it, and then most importantly, some of the novel therapies or treatments that we have that have been remarkable in helping these children with what's used to be a devastating disease. So I'm going to start with the case vignette. This is a 4-year-old boy. He's seen because he's having these recurrent fevers over the past 2 weeks. They're nightly, usually around 6 p.m., spiked to about 104 degrees. He's tired during the day, but he's not miserable. But at night, when he's having his fevers, he is miserable. He's having night sweats and a rash that comes and goes with the fevers. He's been worked up prior to seeing you in an outpatient setting. And it's been essentially normal with the exception of elevated inflammatory markers, the erythrocyte sedimentation rate, and the C-reactive protein being notably elevated. His complete blood count reveals anemia as well as elevated platelet count. He's a bit better taking ibuprofen, but now he's complaining of chest pain and shortness of breath. So here's an example of his fever. So this is the quotidian fever, which is relatively unique to children with systemic JIA. It spikes high, and this is on a centigrade scale here, and then dips below normal actually, sometimes down to 35.5, here showing down to 36. And it typically spikes once a day in this quotidian pattern up to 104, 105, sometimes higher, and is usually around 4 to 6 in the evening, like clockwork. Here's the rash that he has. You can see it's on his trunk. It's on his extremities. It can be anywhere, but those are the most common places. And it's this pink or salmon-colored rash, and it's evanescent, meaning it comes and goes with the fevers. So if you were to circle a lesion, for example, it would go away when his fever goes away, and then it would come back again when his fever returns, and it would be in the same general area or vicinity, but it wouldn't necessarily fill in your mark. So unlike a rash associated with vasculitis, which is dependent on a local blood vessel, this will kind of move around. And so what type of lab finding and imaging do we see with this? So like we said, he had a high platelet count and a C-reactive protein. In addition, they tend to have very high white counts, particularly polymorphonuclear cells or the leukomoid reaction. He is anemic, and this may be why he's having chest pain and shortness of breath. So about a third of these children will have inflammation of the pericardial sac or pericarditis, although maybe only 10% will show up that way at disease presentation. So let's go over the clinical manifestations and the diagnosis of this disease. So this formerly was called Still disease, or in the old nomenclature, systemic onset juvenile rheumatoid arthritis. It's officially classified now under a category of juvenile idiopathic or unknown cause arthritis. It includes children who have daily fevers with this quotidian spiking fever, the rash that comes and goes with the fever, and because this is JIA, arthritis. If this is diagnosed after 16 years of age, and that's a relatively arbitrary cutoff, but nevertheless, it's called adult onset Still disease. And depending on which cohort you're looking at, this makes up about 10 to 20% of all children with juvenile idiopathic arthritis. JIA, or juvenile idiopathic arthritis, is about 1 in 1,000 kids in the United States. So this makes up about 1 in 10,000 kids. Unlike most of the other types of juvenile idiopathic arthritis, it affects the boys and girls roughly equally, and it can peak at onset around 2 years, and children can get this before 2 years, and then that kind of trails off into adulthood where it's called adult onset Still disease. So here's a picture of a child even before the days of corticosteroids and even ACTH. You can see it's a devastating disease. This child is kind of withered away, but you can see he's got joint contractures, joint swelling. He clearly is miserable. His belly is large, though. He may have hepatosplenomegaly. So a really nasty, nasty disease. So what are the articular or joint manifestations that these children have? Well, they may not even have frank arthritis at onset, which makes the diagnosis tough. They may just have joint pains or arthralgias. But when they do get arthritis, it can be one joint, it can be 50 joints, or anywhere in between. The wrists, the knees, the ankles are the most common, but it can affect any joint, including those of the hands, the hips, the neck, the cervical spine, and the temporomandibular joints. And unlike the oligoarticular, few joints, or polyarticular, many joint subtypes of juvenile idiopathic arthritis, the arthritis in systemic JIA can begin in the hips and progress incredibly rapidly, causing severe damage and dysfunction, and may often need to have joint replacements down the road. This also affects their potential for growth in a growing child. So here's an example of the normal knee joint and a completely destroyed one there in B on the right, showing that this arthritis can be as nasty as any type of juvenile idiopathic arthritis. So what are the manifestations of this disease outside of the joint involvement? So fever is a hallmark of this disease, and once again it tends to be these high spiking patterns that can come down to normal or below normal. In fact, if you don't see that, it often puts the diagnosis in doubt. Although having said that, we did a study a while back that showed only about a third of the children have that classic pattern at diagnosis, making the diagnosis tough. These children do appear sick, so they often are hospitalized when they present, but they don't look so bad when they're not having their fever, typically during the daytime hours. So here again is the rash that we typically see with this. This is one of these extra-articular manifestations. It's not fixed. It comes and goes with the fevers. It's a salmon or pink-colored rash. Tends to be on the trunk, but can be anywhere, including the face. And it's also characterized by this Kevnerization phenomena where they either itch or scratch or traumatize their skin, and you get a line along those marks. So what other extra-articular manifestations? Well, this is the most dangerous one. This is macrophage activation syndrome, which is common to a lot of rheumatic diseases, but particularly children with systemic JIA. Up to 30 to 40% will develop this either in a suboccult or subclinical kind of form or a severe overt form. And it can occur usually at onset or with any kind of flare of the disease. And it should be treated as a life-threatening emergency. And it's characterized, unlike the typical flare of systemic JIA, with a persistent fever. The rash is atypical from the usual rash. And they have coagulopathic findings both clinically and by laboratories. They also can become pancytopenic, so their white count, their red blood cell count, their platelet counts will all trend down, even if they started out elevated. They can be normal, but trending down is a sign. They can have liver enzyme elevations or hepatitis. And the hallmark finding is severely elevated serum ferritins or hyperferritinemia. An international group actually came up with classification criteria for diagnosing macrophage activation syndrome in the setting of a child with JIA, systemic JIA, or in a child prior to diagnosis with suspected JIA. And the first thing you have to have is the fever. And then you have to have an elevated ferritin. And this ferritin value of 684 nanograms per mil is relatively low, so not very stringent. And then only two of the following. And if you'll notice, most of these lab numbers here, whether it's the platelet count or the triglyceride level or the fibrinogen level or the liver enzyme elevation, are close to normal. Nevertheless, these are very sensitive and specific and are useful in the setting of children with systemic JIA. So what signs do these kids have? Well, these kids are even sicker than the average child with systemic JIA. And like I said, their fevers tend to be persistently elevated. They don't wax and wane as much. An ominously bad sign for these children is when their erythrocyte sedimentation rate starts to fall while their C-reactive protein, another marker of inflammation, is rising. And that's because one of the major drivers of the erythrocyte sedimentation rate is the fibrinogen level. And fibrinogen gets consumed with the coagulopathic process, and thus the sed rate tends to fall. Like I said before, the other parts of their CBC fall as well: their white count, their platelet count, and they're anemic. And the ferritin can get incredibly high, tens of thousands, sometimes hundreds of thousands. They do have coagulopathic findings, such as abnormal coags like the PT and PTT or elevated D-dimers. The liver is unhappy, so you'll see liver enzyme elevations. And if you biopsy, for example, if you're trying to rule out cancer, you will often see hemophagocytosis, which are these activated histiocytes or macrophages consuming other cell types on the biopsy. One of the pathobiologic findings in macrophage activation syndrome is that these children with systemic JAA, about 30 to 40%, will have heterozygous or single copy mutations in perforin-mediated cytolytic pathway genes. So both natural killer cells and cytotoxic CD8 T cells use this pathway to lyse infected cells or antigen-presenting cells. And these children will often have a single copy mutation either in perforin or in one of these other genes, MUNC13.4, for example. What other extra-articular manifestations do we see? So they often have enlarged livers, because their liver is unhappy, their spleens are enlarged, and they can have significant lymph node enlargement as well. As we saw in that earlier child, they can have pericarditis or inflammation of the sac surrounding the heart and other forms of serositis such as pleuritis. They can also have lung manifestations, and a very small subset of these children are incredibly ill. So they have what looks like interstitial lung disease or other lung pathologies, and can also develop pulmonary hypertension. And a lot of these children also develop MAS in this small subgroup, and this group is a relatively newly described subset of these children who are very, very sick. Sore throat or pharyngitis is much more common in the older children and the adult onset Still's disease patients, but can happen in the younger children, just less commonly. And these children with systemic GA at diagnosis can be confused with Kawasaki disease, another type of vasculitis, or atypical Kawasaki, because in that disease, one of the hallmark findings is coronary artery dilatation, and this can occur in a small subset of children with systemic JA as well. So here's an example of an enlarged lymph node in a child with systemic JA, and for whatever strange reason, it has a predilection for the armpit or the axilla. So just to summarize kind of the lab findings in children with systemic JA, but not necessarily macrophage activation syndrome, is their white counts will go up, their platelets will go up, they'll become anemic. Their markers of inflammation, the ESR, or erythrocyte sedimentation rate, the C-reactive protein will go up. In general, they tend to be anti-nuclear antibody or ANA negative, as well as rheumatoid factor negative. They will get high ferritins, even if they don't have macrophage activation syndrome. Some of them will have this subclinical form of MAS, so they may have elevated markers of coagulopathy, such as the D-dimers, and liver upset, including aldolase. So this is a diagnosis of exclusion, so how do we go about making it? So number one, these children have fevers, so we need to make sure they don't have infections. That's the most common cause of fever in children. Malignancies such as leukemia and lymphoma can mimic this, and other rheumatic conditions that are seen, including Kawasaki disease, that we just touched on. The older teenage girls, we're always keeping systemic lupus erythematosus, which can give you fevers and a variety of features such as arthritis. And then in the very young children, we worry about recurrent or periodic fever syndromes, which are these autoinflammatory or disorders of the innate immune system that most all have genetic origins. These include things like cryopyrin-associated periodic fever syndromes, familial Mediterranean fever, and others. So to help with this, we get a variety of tests, blood and urine cultures to rule out infections, imaging studies, including concern if they have chest pain, we might get an echocardiogram, bone marrow examination if we're trying to rule out leukemia or lymphoma, and this is where we may see signs of macrophage activation syndrome if we see hemophagocytosis. If a lymph node is easily accessible, the biopsy can also help rule out lymphoma. And we consider genetic testing for periodic or recurrent fever syndromes, but this will take time. In the future, S100 proteins may also have the potential to help us distinguish systemic JA from other causes of fever in childhood. So there are now criteria or diagnostic criteria for systemic juvenile idiopathic arthritis developed by the ILAR, or the International League Against Rheumatism. And this includes arthritis in one or more joints preceded by at least 2 weeks of fever. At least 3 days of that have to be in a quotidian or high spiking pattern, plus one or more of the following features: the salmon-colored, non-fixed evanescent rash, serositis, for example, inflammation of the sac around the lungs or sac around the heart, enlarged liver or enlarged spleen, and generalized lymphadenopathy. So for adults, there are Yamaguchi criteria and other criteria, but these are displayed here for adult onset Still disease. And it's likely the same disease, just presenting in adulthood. And there you need 5 criteria, of which 2 are majors, including the high fever. Here they're not even requiring arthritis as much as arthralgias or joint pain, the classic rash, high white blood cell count, typically polymorphonuclear cells or granulocytes. The minor criteria include a sore throat, enlarged lymph nodes or spleen, liver dysfunction, and the lack of a rheumatoid factor or an anti-nuclear antibody. And again, it's a diagnosis of exclusion, so you need to rule out infections, malignancies, and other rheumatic conditions. So, in summary, when we're trying to differentiate systemic JA from other disorders, we need to make sure there's not an infection like osteomyelitis or a bone infection. Even post-infectious or reactive arthritis can look like this at times. Other autoimmune conditions like Kawasaki disease or lupus. If it's fevers in a very young child, we're often making sure this is not leukemia. And the only other disease that I'm aware of that can give you this high spiking quotidian pattern the way systemic JA does is malaria, which we can usually distinguish pretty easily by a good history. So it's a very distinctive disorder, but it can be very difficult to diagnose, in part because the arthritis may not be present at onset, and the systemic features resemble a lot of other diseases. And there's no specific individual test that tells us this child has systemic JIA. And a lot of times, these children come to the rheumatologist relatively late. So they're admitted to the hospital because they look and appear sick, and they have these fevers. And so infections are ruled out, malignancies are ruled out, and then the rheumatologist is eventually called. So how do we treat this? What are the current treatment approaches for systemic JIA? So a little background, the pathobiology of this is becoming a little more complicated than some of our diseases that are strictly autoimmune. So there is a problem with the innate immune system, or an autoinflammatory condition in a sense, of which IL-1 is often a key player in driving this acute febrile or fever stage. In later stages, some children can have devastating, as we saw on the previous image, arthritis of their joints, very destructive, very erosive. And so there are often two phases, this acute febrile stage and this later chronic stage, which is more a problem with the adaptive immune system or more autoimmune. So they can be both autoinflammatory and autoimmune. So treatment-wise, how do we treat children with systemic juvenile idiopathic arthritis? When we haven't exactly made the diagnosis, when it's early on, maybe their first hospitalization, before we would want to throw immunosuppressive medicines like glucocorticoids at them, we need to make sure there's not an infection or not cancer. And so non-steroidal anti-inflammatory drugs, particularly indomethacin, one of the strongest ones, can be useful for dampening the fever and making the child feel better while we're working them up. Glucocorticoids are kind of a hallmark great drug for any type of inflammation, whether it's autoinflammatory or autoimmune, and these can be used, although nowadays with our newer drugs we don't necessarily even need them. Methotrexate can be used, but it's as an adjunct therapy, and it's good for the joint manifestations or the synovitis, but it's not so great for the systemic features. The TNF inhibitors, which have been a remarkable achievement for children with other forms of juvenile idiopathic arthritis, are not so great at treating the systemic features, but can be helpful if the joints become the primary problem down the road. But we're fortunate enough now to have IL-6 and IL-1 blockers, including two drugs that are FDA approved for this condition in children 2 years of age and older. Anakinra is a drug that blocks interleukin-1, and it's given as a daily injection. It can be painful, and it has been shown 85% of about 20 of these kids were able to markedly improve an ACR 90 response. This is a pretty high bar. A lot of studies will look at an ACR 30 type of response, in this case the adapted ACR 90. And 3/4 of these children did this on anakinra alone. That's without corticosteroids. Almost 3/4 were able to stop anakinra within a year. So this has been a remarkable achievement for children with systemic juvenile idiopathic arthritis. And these are data from a retrospective cohort study from several different sites of about 46 children, I believe, where they received IL-1 blockade with anakinra, and you can see all of the markers over time improving, whether it's the high C-reactive protein or erythrocyte sedimentation rate, the overly elevated platelet count, and the ferritin count dropping. And in panel B there, you can also see the number of joints that are active being dramatically reduced. All the children with the red lines there, those are individual children being tracked over time, had no corticosteroids. So this used to be a disease that we really relied on corticosteroids, and yet some of these children only received anakinra. And on the far right, you can see even the children who received corticosteroids, and that's months there on the x-axis, we could remarkably reduce the amount of steroid burden that these children have. Canakinumab is another option for us. This is another IL-1 blocker. Unlike anakinra, it only blocks IL-1 beta, so it doesn't touch IL-1 alpha, but once again, you can see these high standards, the ACR 30s through 90s, 100 even, comparing the bars on the left sides of the graphs to the bars on the right, where the placebo, remarkably good. It's able to reduce active joint counts, physician global assessment scores, parent global assessment scores, disability scores, C-reactive proteins, fever, rash. Every manifestation improves. And this drug is nice in that you can give it subcutaneously or under the skin every month, as opposed to every day. And there's now long-term both safety and efficacy data to show that it works great, even out to 5 years. So once again, a phenomenal achievement for these children with systemic juvenile idiopathic arthritis. The other IL-1 inhibitor out there, rilonacept, is IL-1 trap. And like anakinra binds both IL-1 alpha and IL-1 beta, it can be given as a weekly injection. And once again, in the clinical trials, showed that it was remarkably better than placebo. The other category we now have are IL-6 receptor blockers. So this blocks the signaling via interleukin-6. And it can be given either IV or subcutaneously, on average every 2 weeks, and the dose varies based on your weight. And it, again, has shown remarkable achievement in a relatively short period of time for improving all aspects of disease, as well as lowering corticosteroid use and the ability to also treat the joint manifestations of arthritis well. So I'm going to end with one more child. This is a patient of mine. She is a 17-month-old girl who presented to me with 9 weeks of fever. She was in the hospital. She was only about 10 kilograms, so a 3-pound weight loss was significant for her. Parents said she didn't have a lot of energy and really didn't want to even play anymore. Her fevers were nightly, and they were associated with this classic salmon-colored rash that came and went on her chest and belly. When I examined her, she protected her right knee, and it was warm and swollen. She had arthritis there. And her admission complete blood count revealed a very high white count, mostly polymorphonuclear cells. She was anemic, and she had signs of inflammation by an elevated platelet count. The next morning, after receiving a single dose of one of the IL-1 blockers, I came in to see her. She was on the floor. She was dressed up. She was cleaned up. She was playing. She was smiling, and her fever was gone. And you can see her labs on the left there at admission, and her labs 10 days later. And you can see the markers of inflammation improved. She had some subtle signs of macrophage activation syndrome, the elevated D-dimers and ferritin, and those were improved. She actually had one of those perforin mutations that we talked about in terms of the macrophage activation syndrome. And she was off all meds by 16 months and remains off meds today. So she's done remarkably well. So in conclusion or summary, the advent of therapies such as IL-1 blockers and IL-6 blockers for systemic juvenile idiopathic arthritis have made a huge difference for these children and their families, often without even requiring long-term corticosteroid requirements or dependence. We always still, as physicians, need to be cautious of the entity of macrophage activation syndrome in a child with systemic JIA. Unfortunately, with their future directions, we now are trialing either IL-1 blockers or gamma interferon blockers for treating macrophage activation syndrome to overcome that hurdle in these children as well. I thank you for your time.
This CME-MOC-CNE activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/AVC. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.